Good afternoon, class. We are reviewing chapters 25 and 26, the sensory system. And really, when you think about the sensory system, it has to do with every part of taking care of a patient because of the decreased vision, decreased hearing can, cover over into every aspect of care as far as orienting your patient to their environment, maintaining safety. There's a lot of eye diseases that we're going to cover in chapter 26, and also diseases of hearing, and so lots of information to cover. I do want to remind you in chapter 25 at the beginning for your key terms that are in blue, make sure you know all of those definitions and are familiar with those. Chapter 25 starts out with reviewing the structure of the eye. And I know you had this in anatomy. I was just going to briefly go over a few things for review. Your eyelids, eyelashes are protective for the eye, making sure that foreign objects don't get into the eye, that the eye is not harmed. Your lacrimal glands produce tears that are going to moisten, lubricate, and protect the eye. The sclera is a white part of the eye. The cornea is transparent. The choroid is the muscular middle layer of the eye. Ciliary body produces aqueous humor. When we start into chapter 26, we're going to talk a lot about aqueous humor and if it's not draining properly and how that is going to cause a lot of problems with glaucoma. Your iris constricts and dilates is the colored part of the eye. And the cornea allows light to hit the lens, allowing the bending of the light, hitting the retina, and transmitting the impulse to the brain, which is really the physiology of vision, so to speak. So look over those structures and don't spend a whole lot of time on it, but make sure you understand the structure and anatomy of the eyeball. Okay, you have some really good diagrams on page 572, 573, where you can look at your different structures of the eye. And when you're looking at the labeling, I would like for you to pay attention to the anterior chamber, posterior chamber, where the lens is located, the optic nerve. Of course, we want to preserve the function of the optic nerve, very important in vision. And that's really a major priority in preventing blindness, is preserving the optic nerve. And hopefully you got your PowerPoints that were sent over to you. Okay. Wanted to also mention the optic disc. If it appears swollen, that means that increased intracranial pressure can be increased. The optic disc, you will see it is near the back of the eye where you see the optic nerve there and the branches of the nerve coming out. So be familiar with that, just in briefly looking over your anatomy. And also figure 25.2 showing your visual pathway, just a real interesting diagram to look at there. Muscles of the eye are in table 25.1. They cause relaxation for close vision and allow light to enter the eye. So we do not have to memorize those different muscles of the eye, but just know that there's extrinsic and intrinsic muscles of the eye. And you see a lot of listing of your cranial nerves there. So now you get into some specific functions of those, but like I said, no need to memorize that. Just know that there are intrinsic and extrinsic muscles of the eye. And I would like for you to be familiar, as I said, with your blue terms at the beginning of your chapter. Also make sure that you know about hyperopia, myopia, and astigmatism. You will see these terms come up when you're dealing with the eye. You'll see them probably on your NCLEX, and you'll kick yourself if you get them mixed up. So just think about if you have someone who is around 40 years old and starts having to use readers to see that they're just buying over the counter. For example, me, I am just using over-the-counter glasses that I'm buying at different places, and just to try to improve my vision because I have hyperopia or farsightedness. So know those terms. Myopia is nearsightedness, and astigmatism is an irregular shape of the cornea or lens. So even little kids can need to have glasses for astigmatism. Okay. Presbyopia is loss of vision with age. I think that's one of your blue terms as well. Yeah. You have a picture in the middle of 573 arcus sinalis, which is deposits of fat around the cornea, which can cause a white ring around the cornea. So be familiar with that as well. Also, ectropion, which is a version of the lower lid, and that's just because of a loss of muscle tone. And these have to do with just visual changes that happen with age. Read through that age-related eye changes section as well. The muscles of the eye do not work as well as someone ages. So age-related visual changes have to do with changes in accommodation. And just to review a little bit, we have decreased elasticity of the lens, difficult peripheral vision, decreased pupil size, difficulty with night vision, sensitivity to glare, distorted depth perception, and decreased lacrimal secretions. So the lacrimal secretions of the eye help to protect the eye, as we just said. So the patient who is getting older, usually after maybe about age 60, is going to have less tear production, less lacrimal secretions, so they're more prone to have corneal injuries, pain in the eye because of this, and may have to use some artificial tears. That can be one of the first things that happens. And we also want to stress how important it is to have eye exams for really everyone. So when you have your people that are coming in for just their general checkups, ask your patients, are you having an eye exam? Someone that is in the range of you guys, you know, you may just need to have an eye exam every 2 or 3 years. Your book talks about from age 40 to 54 every 2 years, age 55 to 64, 1 to 3 years, and over 65, an eye exam every 1 to 2 years. And certainly if a patient has hypertension or diabetes, they need to make sure and be having a yearly eye exam, as those conditions predispose them to blindness. So that's important. By an ophthalmologist. When we're talking about an eye exam, I'm not talking about just going into your general practitioner, having them do the Snellen chart. I'm talking about going to an ophthalmologist. And if someone injures their eye, also, it's important to see an ophthalmologist as well. I know that sometimes people get injured on the job, think they get something in their eye, get hit in the eye. They always do need to see an ophthalmologist. You cannot diagnose what's going on without looking at the eye with an ophthalmoscope, or maybe even a more, sophisticated eye exam. So in your nursing career, if you have someone that talks to you about getting hit in the eye, they're playing a sport, they get hit in the eye with a tennis ball, something like that, yes, they need to go to an ophthalmologist. So back to your aging visual changes with the eyes. Vitamin A is important. You have a little blurb in your book about that for preventing night blindness. On page 574 in the red nutrition considerations, vitamins and antioxidants beneficial to vision. And we do want to prevent eye injury, of course, using goggles if someone is working with welding something, of course, or something like that. Also, there's some easy things that can prevent trauma to the eye. Wearing sunglasses out in the sun is very important to protect the eyes. Medications can cause some eye damage. Chronic steroid use is associated with eye disorders. Smoking is associated with more eye disorders. Diabetes, as we just said. And there's 21 million blind or visually impaired persons in the United States. 5.4 million of those are over 65 years old. But there are some eye diseases we really want to try to prevent. Glaucoma, macular degeneration, which we are going to talk more about in chapter 26. And as I said, we want to try to prevent chronic dry eye. That can be a danger sign of eye disease. As someone ages, like I said, they have less production of protective natural tears, lacrimal secretions. They also have possibly trouble with color vision, night vision, seeing colored light flashes. All of those things can be danger signals of eye disease as well. Okay, let's talk about the Snellen chart for just a moment. And Snellen chart for you, let's see, page number, I'm not sure, I'm sorry. But read through the section in your book about assessing someone's eyesight with the Snellen chart, because that is a very simple way, and I'm sure you've had that done to you yourself when you've went in for a checkup. But when you're thinking about your Snellen chart, remember that normal vision is 20/20. Legally blind is 20/200. And that means that, just to get the definition out for you, you see at 20 what the normal vision can see at 200. So that's bad, okay? That means your vision is impaired. And if your vision is, say, 20/70, that means you see at 20 what the normal person could see at 70 feet. So you're very much impaired and need to have corrective lenses at that point, of course. But legally blind is 20/200. So you're seeing at 20 feet what the normal vision can see at 200 feet, okay? When using the Snellen chart, someone needs to cover up, usually there's a little piece of cardboard or something, to cover one eye to test and just see which level of the Snellen chart that they're going to be able to read. And I think you have, no picture of that, sorry. But it should be in your book. I just can't remember exactly what page. And you're using an ophthalmoscope to look in someone's eye. And, you may not feel trained to do that, of course, at all. I know you probably covered that, maybe in anatomy, I'm not sure. But usually the physician that comes around, or if they get a consult by an ophthalmologist, is going to pick up the ophthalmoscope that's plugged up somewhere at your nurse's station, take it to the patient's room, dim the lights, and turn it on to check the structures in the eye. So your job as a nurse is just, when you're doing your checklist for your nurse's station there, just make sure it works. Turn it on and make sure that the light is working. Okay. All right. I will add, okay, someone who is, let's say that I have an eye injury or my eye hurts or something like that, and I go in to get a checkup. So they may use some 1% atropine drops for dilation to look at the structures in my eye and see if they see anything in there. Basically, the ophthalmoscope is used to examine the back part of the eyeball, including the retina, optic nerve, macula, and the blood vessels. And when you're assessing a patient, always make sure that you are taking into consideration their age, because the older we get, of course, we're going to have more problems with our eyesight. Have I had a previous infection before with my eyes? Have I had a previous injury before? Have I been treated for cancer? Do I currently have a tumor? Do I have diabetes? Is anyone in my family had glaucoma or had an eye disease? Do I have hypertension? So take those things into consideration when you're gaining assessment information about your patient. Diagnostic test. There is a great big chart about diagnostic testing beginning on 576, and it's like 3 pages long, okay? It is a big chart, but I do want you to spend some time, spend 30 minutes or so looking over this chart to make sure you know the description of each of these different diagnostic tests. Tonometer is important that you remember what that is. It's just used to check intraocular eye pressure. That is in the middle of page 577. Look at what you would explain to your patient. It can be a little uncomfortable. You may have had it done to yourself before. Air is directed at the eye, and the person has to sit still. It's a handheld instrument, and you have a picture of it at the top of page 576. So look through all of these different diagnostic tests for the eye. Keep in mind when you are at the bottom of page 577 looking at corneal staining to see if there is a cut in the cornea or an abrasion or laceration of cornea. You know, it may certainly be that if someone has eye trauma that you see it, but it could be that you don't always see an abrasion to the cornea. So eye drops can be administered. Check for allergies with your patient. If they have an iodine allergy, you have to be careful with some of the eye drops that are used. So checking for that also. When a person goes in to have these checkups that we talked about every year, every 2 years, whatever, one of the number one things they're also checking for is cataracts as someone ages, but mainly glaucoma as well with the tonometer. Okay. Be aware there are guide dogs, of course, that can be used. We've seen people with that are legally blind with using guided dogs. Nutrition for eye health, very important. We talked about preventatives just a little bit. Also, good healthy diet, green leafy vegetables, very important. And there are just plain old eye vitamins that you can buy at the health food store, vitamin shop, whatever, that have several different things that are beneficial for the eyes as well. So that can be something easy that you recommend to a patient. Keep in mind also, I just made a note on my PowerPoint here, if someone has when you're thinking about safety, a chemical splash to the eye. Remember when you were in high school, if you took chemistry, there's an eye wash station in the corner of the room. So if someone does have something that's splashed into their eye, even if they don't know if it's harmful or not, they need to irrigate the eye with water just by leaning over to the eye station and just splashing the water into their eyes for about 15 minutes to irrigate. Or if you have normal saline, that can be used as well. Also, not sharing things that are associated with the eyes. So not sharing, like teenage girls or college girls sharing mascara or eyeshadow, that's a no-no, because you can transmit infections as well. Okay. Also, I want you to look at, on page 581, installation of eye drops and eye ointment, okay? If I had a $100 bill in front of me, I would say, okay, I bet you this $100 bill that you're going to have questions on your NCLEX exam about installation of eye drops. I've seen it when I've looked over people's shoulders who are taking HESI. I've always seen it on practice test. So be sure and look over on page 581 at the bottom, installation of eye drops. So someone can also be taught to instill their own eye drops as well. I don't think I saw the chart in this book about it, but if someone's going to install their own eye drops, they can hold their hand up over the brow and instill it themselves. That can be done as well. But anyway, if you are instilling someone's eye drops, it goes through the steps here about removing the cap, placing it on the table on its side or upside down, because you don't want to contaminate the top of your eye drops, and backing up just a little bit, making sure you have the right thing to put in your eye. Sometimes little tubes of eye drops can look like little tubes of super glue, so most of the like super glue and stuff have like a really bright colored cap, so you don't get them confused, and it may just not be, you know, super glue, but artificial tears in the little container they come in could look very much like a prescription eye drop that someone's supposed to be using. So they maybe need to keep them in a totally different section. If they have impaired vision anyway and they're installing their eye drops, you know, that can be a problem. So teaching them to place it in an area where they are know for sure they have the right thing to be dropping into their eye. Okay, so with the patient sitting or reclining, ask them to look up at the ceiling, tilt the head slightly toward the eye receiving the drop. With a tissue, retract the lower lid, exposing the conjunctival sac. So that's where you want the drop to go. You don't just want to plop it onto the eyeball. You want the drop to go into the conjunctival sac. Stabilize the eye drop container above the eye. Drop in the number of drops. And you want to also block the entrance to the lacrimal gland by placing a finger over it. That is not with every eye drop, but that's just inside the inner canthus. This is the inner canthus. This is the outer canthus. So putting the finger over the lacrimal sac just to make sure that the patient does not absorb the medication systemically. That's important. Now, I'll put my hand on my eyeball. So, of course, you're going to be wearing gloves, but you're teaching a patient who is administering their own eye drops. They need to be sure and wash their hands prior to administration. You do too, but of course you'll be using gloves. Closing their eyes after administration, moving the eyes from side to side under the lids to distribute the medication. They may have more than one eye drop that needs to be administered, so they need to wait about 10 minutes between the application of the eye drops. And then they also may have an eye ointment to use as well. Exposing the conjunctival sac is important. Using a thin ribbon of ointment along the entire length of the conjunctival sac. And it talks about twisting the tube with a lateral movement without touching the eye to kind of cut off the ribbon of medication. Recapping the tube, and ask the patient to gently close the eyes and roll the eyes around under the lids to distribute the medication. So they need to sit there for just a few minutes after application of eye drops or eye ointment. So be sure and read through that at the bottom of chapter 225 on page 581. All right, so let's switch over to the ear, okay? All right. Okay, structures of the ear. Certainly you already know that the pinna is the part of the ear that you can touch, and it's receiving the sound. Okay, so your pinna, outside portion of the ear. Your ear canal is about 2.5 centimeters, and cerumen is another word for earwax. Cerumen is another word for earwax, okay? So your earwax and the hairs inside of the ear canal are going to be protective to the ear, okay? Your ear is kind of self-cleaning, okay? So you'll see a lot of information about not putting Q-tips into the ear, bobby pins, anything, your pencil into your ear to clean out earwax. It's not important. Just let the ear clean itself. So just externally clean someone's ear with a washcloth. And you see some different structures of the ear here also. Eardrum, your malleus, incus, and stapes, which are like 3 bones in the middle ear, the oval window, and your eustachian tube, which equalizes pressure within the ear. And you have a great diagram on page 583. All right, hearing loss. Of course, older adults are more prone to hearing loss. And I wanted you to pay attention to box 25.2 on page 584 about common causes of sensorineural and conductive hearing loss. And sensorineural is your more frequent loss of hearing, and conductive is all the other types, which is a problem with transmission. Infections or earwax are common causes of conduction hearing loss. Sensorineural hearing loss, aging, loud noise are some of the more common reasons for that. But look at your box, 25.2, purple box, bottom of page 584. So if you have a multiple choice question, you will be able to decide there. And otoscope is used to examine the ears. So if that's at your nurse's station as well, make sure that it is working and that the light comes on when you pop it open. Just some little stats here. Veterans are 30% likely to have some hearing loss.